What is most important in the smooth implementation of a health insurance system? Collecting premiums. That is why in many countries, health insurance first targets the people most likely to pay their health insurance premiums. For example, an insurance scheme might target company employees or civil servants. When a health insurance system was first introduced in Japan, it also targeted those whose premium payments could be assured. A stable supply of insurance funds could be secured by withdrawing premiums from the salaries of insured employees. The next step was to aim toward universal coverage of health insurance, covering the whole population. At that time, however, 80% of Japan's population worked in the informal sector, mainly as independent farmers and self-employed workers, making it very difficult to collect insurance premiums. The Second World War helped raise Japanese awareness of health, and nationwide rates of health insurance coverage went up. Although coverage temporarily decreased after the war, Japan achieved universal health insurance coverage in 1961. So the most salient features of Japanese health insurance are income redistribution with public responsibility and the achievement of universal health insurance coverage with equitable access for all citizens. So how did health insurance develop in Okinawa? Let's start by looking at Okinawa's pre-war health insurance system. Japan's first national health insurance system was established under the Employment Health Insurance Law of 1922. This law was implemented in 1927 as part of national measures undertaken at the time to enrich and strengthen the country. The law began by insuring workers in factories and mines, the same approach as today's employment health insurance. The first region of Okinawa to introduce employment health insurance was Iriomote Island. The workers on this island received insurance first. That was because the island had mines with high-quality coal, and the miners working there exhausted themselves through heavy labor. They were subject to diseases like malaria, as well as beriberi and other sicknesses caused by poor nutrition. Community-managed health insurance at the national level has operated in Japan since 1938. The target of the scheme was farmers, who formed the majority of the population at the time. Behind this was the fact that the Great Depression had forced farmers into poverty, and many could not afford medical treatment. In 1938, when Japan's new community-managed health insurance scheme was implemented, in Okinawa Prefecture, only the people of the Ozato and Haibaru villages on the main island of Okinawa were insured. However, the government did not subsidize medical charges. Because the insurance fees had to provide the whole cost of treatment, the scheme was under great pressure. After the Second World War, Okinawa was administered by the U.S. Army. Because Japan's administrative power did not extend to Okinawa, the region's health insurance was left to take its own course. After the war, Okinawa was left with no health insurance system. Each doctor's fees were set by the medical association of each district. In response to popular demand for health insurance coverage in Okinawa, the Ryukyu government started implementing a health insurance system in 1955. In 1958, the Ryukyu government invited advisors from Japan's Ministry of Health and Welfare and asked them for advice in setting up a health insurance system. Japan's public medical insurance is roughly divided into employment health insurance and community health insurance. Employment health insurance is for people employed in company or factory workplaces. Community health insurance is for farmers and the self-employed. Community health insurance is essentially all community managed.
The preparatory work for Okinawa's health insurance prior to 1958 simply adopted the mainland system. This represented the basic philosophy of the Ryukyu government. However, in the case of the mainland, health insurance was divided into several systems, and the people were covered by one of these. This resulted in various discrepancies among the different systems. A large number of system and financial problems were identified. Accordingly, the Ryukyu government switched its policy to designing a system suited to Okinawan conditions and invited advisors from Japan to give advice.
Advisors from Japan's Ministry of Health and Welfare offered the following advice on the creation of a health insurance system suitable for Okinawa. This system was to be based on the mainland's health insurance system. Cover the total population in Okinawa, implement an insurance-based system, not tax-based, implement a reimbursement scheme. Under the reimbursement scheme, the patient must first pay the total consultation fee to the clinic, hospital, then seek reimbursement according to their benefits at an insurance office. In contrast, the coinsurance scheme was based on the patients paying a certain percentage of the consultation fee directly to the clinic or hospital. The cost of that direct payment was not covered by the insurance. As the remainder would be paid from the health insurance, this was called a coinsurance scheme. On the mainland, the coinsurance scheme was used.
In other words, we wanted to avoid repeating the pattern of the mainland experience. In a small socioeconomic environment like Okinawa's, splitting the system would weaken its management underpinnings, so we sought to cover the whole population under a unified system. Also, there was the problem of limited medical resources. At that time, the situation was quite bad. That is why we decided on a reimbursement scheme rather than a coinsurance scheme. We would thus remove the seeds of any future problems, including the limitations on medical treatment that could accompany the coinsurance scheme. Another problem we wanted to avoid was the possibility of getting into the red because of a sudden increase in the cost of medical treatment. Still another reason to adopt the reimbursement scheme was to avoid the bottleneck accompanying the management techniques needed for overcoming the troublesome task of examining the content of the medical care. In other words, we sought a framework that was workable in view of the reality of Okinawa's conditions.
The Medical Association strongly advocated the reimbursement scheme.
For the patient receiving the medical care, the coinsurance system was more convenient. However, in the framework of medical care delivery, the doctor implementing the coinsurance scheme found that system inconvenient. After treating the patient, there was still desk work and quite complicated health insurance claims to file. In terms of time and labor, there was a lot of work for the doctor and medical staff. The mental and physical burden of this paperwork was considerable. One look at the situation on the mainland revealed what would be in store if Okinawa adopted the coinsurance scheme. Considering the conditions in Okinawa and the long-term effects on the medical staff, the reimbursement scheme was deemed better.
The Ryukyu government considered health insurance based on the advice of Japan's Ministry of Health and Welfare, but had misgivings in relation to insurance financing. Insurers on the mainland received subsidies from the government, but Okinawa was under the administration of USCAR, the U.S. civil administration of the Ryukyu Islands. In the United States, there was no compulsory sickness insurance, so the idea of subsidies for health insurance did not receive a sympathetic hearing from USCAR. On the Japanese mainland, a new community-managed health insurance law was implemented in addition to the familiar employment health insurance. As a result, in 1961, Japan attained universal health insurance coverage. The Ryukyu government tried to create an employment health insurance scheme as the first step toward universal coverage of health insurance. However, many opinions were received from the Okinawa Prefecture Medical Association and policyholder groups, and for every step forward, there were two backward. The Okinawan health insurance law was finally approved in 1965. The main points of the law were adoption of employment health insurance, adoption of the Reimbursement Scheme, and universal coverage of health insurance by 1970. As a result of this law, employment health insurance was also expanded in Okinawa in 1966. The insurer was the Ryukyu government. Policyholders were companies with more than 5 employees and employees of local authorities at city, town, and village level. About half the population of Okinawa was covered by the new law.
Looking at the state of medical treatment in Okinawa at that time, even if health insurance were adopted in Okinawa, there was an extreme shortage of doctors, and the few that were there were concentrated in the cities. Under these circumstances, some of us thought that unifying the reimbursement and co-insurance schemes would be best. When introducing insurance, it is necessary to consider the basis for funding it. There is also the problem of controlling the level of medical fees. If the reimbursement scheme were adopted, the medical fees would be what the people were used to paying. The people would pay this up front to the doctor. Starting from the reimbursement scheme and employment health insurance system was, I thought, very good and a realistic way of approaching the problem. The Ryukyu government-run employment health insurance used the reimbursement scheme. The big problem with this was that although people had paid their insurance premiums and were covered by health insurance, unless they had cash in hand, they could not access medical institutions. A patient would be seen by the doctor, pay cash for the treatment, receive an inventory of the charges, then go to the health insurance office to apply for reimbursement. But often the insurance office was a long distance away, and there would be travel costs involved in getting there. It would often take a whole day, and if the charges were small, it would not be worth the effort. Sometimes patients would just not bother claiming their charges. The cumulative effect of this was a substantial profit for the insurer.
The reimbursement scheme was not user-friendly for the policyholder, and trade unions and others pushed strongly for a shift to the co-insurance scheme. There were also mounting calls to speed up the introduction of universal health insurance coverage. Those involved in health services also had powerful misgivings about limiting health insurance to employees only. Looking at the finances of the health insurance system at that time, revenues from policyholders expanded while outgoing disbursements were small. The result was an accumulation of surpluses year by year. Support from the U.S. authorities and the Japanese government was unstable. In January 1968, when the reversion of Okinawa to Japan was clearly imminent, the Ryukyu government invited advisors from Japan's Ministry of Health and Welfare, asking them to conduct a study on implementing universal health insurance coverage in Okinawa. The advice of this study was to adopt a separate community health insurance system alongside the current employment-based insurance. The reasons for this were the state of medical institutions in Okinawa, the need for smooth operation of the system when Okinawa was reverted to Japan, and the administrative convenience of collecting the insurance premiums. Taking notice of this advice, in May of 1968, the Ryukyu government announced its intention to adopt Japan's universal health insurance coverage system in an effort to standardize its approach with the mainlands. It also announced it would change to the co-insurance scheme.
The Ryukyu government focused on the question of whether to adopt the mainland approach of a parallel system of employment health insurance and community health insurance, or whether to take a unique Okinawan approach of a unified system embracing employment health insurance and community health insurance. Finally, with the return to the mainland imminent and the need to develop a post-reversion system, the Ryukyu government decided to adopt a parallel system like the mainland's. The new parallel system developed by Okinawa would conform to the mainland's community-managed health insurance scheme.
However, the Okinawa Prefecture Medical Association, the Dental Association, and the Pharmaceutical Association were strongly opposed. These bodies advocated an Okinawa government-run unified health insurance system and would not tolerate a parallel approach.
Incomes on Okinawa were low. Doctors were in short supply, and there were many outlying islands and remote areas. Considering these conditions, a parallel system consisting of community-managed health insurance and employment health insurance would lead to a financial gap between the two schemes. The Medical Association could not allow this to happen. It fought for a unified health insurance system that would be fair and redistribute incomes to the local people.
The Okinawa Prefecture Municipalities Association also advocated a unified system, fearing that the health insurance system might run at a loss if the cities, towns, and villages became the insurers. In November 1968, Chobyo Yara of the Progressive Party was elected chief executive of the Ryukyu government. Under his administration, the concept of the parallel system was preserved. The Okinawa Prefecture Medical Association and others who advocated the unified system clashed head-on with representatives of policyholders who supported the government's parallel system proposal. No common ground was reached, and the session of Parliament finally stalled. Let's look at the advantages and disadvantages of the unified and parallel systems. First of all, how did Okinawa correspond to the Japanese system after the reversion?
One way of achieving universal coverage of health insurance was to adopt a unified system. This would create a community-managed health insurance system for people not so far included in the employment health insurance. The Ryukyu government, rather than the municipalities, would create and run the unified system. This idea was based on the reality that the system for delivering medical care was poor, but the problem was how the system would change after the coming reversion of Okinawa to Japan. Even if the unified system were to continue transitionally as a system unique to Okinawa, sooner or later the employment health insurance and the community-managed health insurance systems would have to be dismantled and separated, then rearranged to match the system on the mainland. For the Ryukyu government, becoming the insurer was a difficult option because of the need to standardize with the mainland. Even though Okinawa reverted to Japan, there were still some aspects of its health insurance system that could not be unified with the mainland system. Some parts could be integrated and some parts couldn't. In relation to medical treatment, gradually the demands of doctors and care deliverers were recognized, and medical personnel achieved more of their demands. We considered that the differences under the system, based on Okinawa's health insurance law, which was different to the mainland's, would need to be gradually eliminated over a period of 2 or 3 years. One method of achieving high health insurance coverage is a parallel system. This would target the residents of Okinawa who were not included in employment health insurance up to now. We would create a community-managed health insurance system administered by the municipalities as on the mainland. One advantage of this was that the reversion of Okinawa would not cause too much disruption because the mainland also used a parallel system. The only change after reversion would be the separation and rearrangement of the employment health insurance system run by the Ryukyu government. It was natural that reversion would result in some people joining the employment health system and some joining the community-managed health system. So it was thought that, for the Ryukyu government, embracing a parallel system would be better for the future of insurance in Okinawa.
How was Okinawa's insurance to be financed? Revenues were the biggest issue in the debate surrounding universal health insurance coverage.
If Okinawa adopted a unified system in contrast to the mainland's parallel system approach, the Ryukyu government had little hope of receiving government subsidies from the mainland to finance the community-managed health insurance component of its unified system. If this happened, the Ryukyu government would have to provide all of the finance to insure its citizens. Also, the problem was that policyholders who were not in the employment health insurance scheme had no employer to supply half of their premiums, so who would provide the portion of the premiums otherwise provided by the employer? On the other hand, if a parallel system were adopted, Okinawa would receive government subsidies, although these would not necessarily be enough. In the cities, towns, and villages of the mainland, any shortfall was made up from the general account. This is how the deficit was covered. But the municipalities of Okinawa, which were much poorer than the mainlands, had no hope of making up the deficit themselves.
Could Okinawa deliver benefits to its citizens?
Where employment health insurance and community-managed health insurance were implemented under the so-called parallel system, there were situations where patients could not be treated because the medical delivery system was not sufficiently developed in many towns and villages. The cities fared better than Okinawa's towns and villages. It was thought that gaps between employment health insurance and community-managed health insurance would appear in respect to the delivered content and the burden of the insurance premiums. At that time, employment health insurance covered the cost of childbirth and funerals, but under community-managed health insurance, these were optional extras. Adopting a unified system run by the Ryukyu government would eliminate the gaps that appeared in a parallel system. The Medical Association advocated that the benefits of health insurance should be enjoyed fairly by all citizens. A unified system would be closer to the ideals of this kind of Social Security approach. The Japanese government drew up a financial support budget for 1970 and 1971 in preparation for the implementation of a community-managed health insurance system in Okinawa. But unfortunately, this budget was not executed because the Ryukyu government could not decide on a system.
In November 1970, the Japanese government released the first outline of Okinawa reversion, which set out the framework for Okinawa after reversion. This outline specified the government's intention to apply the mainland's health insurance-related laws at the reversion of Okinawa. In February 1971, Okinawa's parliament was reconvened, but things did not go smoothly. In September 1971, the Okinawa Prefecture Medical Association, the Dental Association, and the Pharmaceutical Association joined with the Liberal Democratic Party in presenting a bill to comprehensively amend the content of the Ryukyu government-run community-managed health insurance system. On the last day of the session, the bill was passed. The unified system was approved by Parliament. All that was needed now was the signature of the chief executive of Ryukyu government to sign the bill into law.
The unified system had been approved by Parliament, but several problems remained before it could be implemented. To overcome these problems, the Ryukyu government proposed a compromise solution. It would take on the role of insurer along with the municipalities, but the municipalities would have the choice. With this as an alternative, the Ryukyu government firmed up its legislative recommendations. Accordingly, the chief executive of the Ryukyu government refused to sign the bill, which had been approved by Parliament, and the measure was rejected.
The Okinawa Medical Association and others who were dissatisfied with the rejection of the bill resigned en masse from work under the Employment Health Insurance Scheme that December. This threw medical insurance in Okinawa into disarray.
Because the chief executive of the Ryukyu government had refused to sign, the members of the Ryukyu parliament resigned en masse in an effort to call him to account. But this was not a rejection of the health insurance. Although they had rejected the health insurance scheme, all the medical institutions still continued to issue receipts to patients. As long as the patients retained their receipts, they could claim their medical costs. The Ryukyu government had a hard time breaking the deadlock. The vice executive of the Ryukyu government and the director general of the relevant bureau formed the nucleus of a group to seek the cooperation and understanding of the medical establishment, which had been told by the government that it should accept the compromise solution. Many efforts were made to sway the medical establishment, but in the end, these ended in failure. With the reversion of Okinawa, the attitude of the Japanese government was that if the Ryukyu government passed a community-managed health insurance law before the reversion of Okinawa, even if this was different from the law of the mainland, the Japanese government would respect the Okinawan law as reflecting the wishes of the Okinawan people and would not require the law to be changed immediately. However, pre-reversion Okinawa could not go along with this.
In May 1972, shortly before reversion, the Ryukyu government abandoned the enactment of a community-managed health insurance law because it could not obtain the agreement of the Okinawa Prefecture Medical Association and the rest of the medical establishment. On May 15th, Okinawa was reverted to Japan. From that day, the mainland's health insurance-related laws applied. The mainland's community-managed health insurance scheme was now introduced without modification to Okinawa. The Coinsurance Scheme was implemented in Okinawa for the first time. Before this, at midnight of May 14th, the Okinawa Prefecture Medical Association, the Dental Association, and the Pharmaceutical Association withdrew their refusal to work under employment health insurance and decided to restore their full support.
If the health insurance doctors continued their rejection after Okinawa's restoration to Japan, the Okinawan people could not receive health insurance. The mainland's health insurance contained many contradictions. Anyway, the important thing was that the people of Okinawa receive health insurance. The doctors could not allow themselves to prevent people from receiving health insurance. The Medical Association decided to work and cooperate to ensure the smooth introduction and implementation of the mainland insurance system into Okinawa.
At the time of reversion, the surplus generated by the employment health insurance stood at 12.6 billion yen.
An act of the Okinawa Parliament immediately before reversion approved the division of the surplus between the special consolidated account of the former health insurance scheme and Okinawa Prefecture's Medical and Welfare Fund. According to my recollections, the Medical and Welfare Fund received around 7.5 billion yen. Anyway, these arrangements were made so that the municipalities could use this as working capital in operating the community-managed health insurance scheme.
Because preparations prior to reversion were insufficient, special reversion measures had to be passed to allow the community-managed health insurance scheme to start by 1974.
The implementation preparations of the cities, towns, and villages were all at varying levels, so their states of progress were completely different. We therefore divided the cities, towns, and villages into different groups. We identified the most advanced and least advanced, giving them all a rating in order of preparedness. For each group, we set a date for starting implementation and began helping prepare them with this date as the goal.
We did not have enough research to guide the municipalities in the detailed aspects of paperwork needed to help them prepare for quick implementation.
Just before reversion, the basic policy of whether health insurance would be run by the government or by the municipalities was still undecided. Almost none of the cities, towns, and villages had started preparing to implement. The relevant departments and agencies of the government were also unprepared to lead in the implementation. Finally, to support the needs of the cities, towns, and villages, the government divided Okinawa Prefecture into 5 wards and held mass meetings in each ward to explain how the system would operate. The meetings focused on the interpretation and application of related statutes and regulations, but in reality, the meetings were more mutual study sessions than opportunities to provide advice or leadership. I heard that it was very difficult to get staff to implement the system on the outlying islands and remote parts of the main island. In the case of outlying islands and remote areas, a major impediment was the quite poor transportation and communications at that time, which inhibited contact with the center. Another difficulty for the municipalities was getting the people to understand how the new system worked. In particular, as it became clear how much each household would have to pay, we heard of many cases of people refusing outright to join the system, claiming they couldn't afford it or that they didn't need insurance because they never got sick. But when some of those people who refused to join did get sick and needed treatment, they finally realized the value of the scheme and joined. Anyway, it took time to convince people of the merits of the new scheme. But we could not afford to wait for everyone to come on board. Sometimes it was necessary to start the scheme before obtaining the consent of all concerned.
In 1973, 12 years after the mainland, whole municipalities spread community-managed health insurance to the population. Okinawa Prefecture now had universal coverage of health insurance to the population. In 1975, Okinawa Prefecture Community-Managed Health Insurance Organizations was established to enable the insurers to work together to offer the necessary services. The insurers began working to develop their operations, starting with screening and payment of medical charges. After that, the operational basis of Japan's health insurance weakened as the population began aging and because of social and economic conditions. To stabilize the system, many reforms were undertaken. These included reviewing the scale of benefits and establishing an elderly health insurance system, a healthcare system for the retired, and a nursing care insurance system. Looking at the 1993 rates of insurance dues collected for Okinawa Prefecture's community-managed health insurance, that is, the payment of insurance fees to the insurers, the outlying islands and farming villages paid the most. The rates of premium payment for Naha City were the lowest. The decline in the rates of premium payment for the cities was the main factor in the decline in the average rate of premium payment for Okinawa Prefecture. This state of affairs had to be addressed in order to maintain and strengthen the finances of community-managed health insurance in Okinawa and to distribute the burden of costs fairly. Because the reimbursement scheme was used before the reversion of Okinawa to Japan, the rate of subsidy was about 1/10. But after reversion, the rate of subsidy of community-managed health insurance under the Coinsurance Scheme was more than 70%.
In Okinawa, which was a major battleground in the Second World War, the post-war reconstruction started on the back of a destroyed economy and social structure. Many people died of malnutrition and infectious diseases at that time. There were not enough medical facilities or doctors, and people did not have good opportunities for receiving health care. On top of this, many people could not avail themselves of health care because they couldn't afford the cost. Calls for the establishment of a health insurance system increased daily, and public opinion drove it. However, Okinawa was under the occupation of the U.S. Army, and the financial base of the Ryukyu government was weak. In addition, the cities, towns, and villages were small, and their finances were poor. Okinawa was not able to implement a universal health insurance coverage system that could provide health insurance to all the people. Because of these background conditions, only 40% of the population had employment health insurance, and the user-unfriendly reimbursement scheme was used. The relevant parties, such as the Ryukyu government, the municipalities, and the medical association, all agreed in wanting to create a universal coverage of health insurance system as soon as possible. However, with the major social changes of reversion imminent, there was great enthusiasm to embed a health insurance system as part of a better social security system that would avoid the problems of the mainland's system of health care. At the same time, the aim was to standardize Okinawa's insurance system with the mainland's, but with the time schedule for reversion looming and the medical establishment and the government not yet in agreement, the two sides were overtaken by events. After nearly 40 years, the people now knew what shape health insurance should take, and their thinking had not lost any of its force. The thinking remains relevant today. Medical treatment is one essential social foundation stone for building a stable and affluent society. However, considering that the incomes of those insured were low, premiums were small, medical costs would increase, and insurers would fall into the red, a system supported by public funds was needed. Also, if people paid health insurance fees but couldn't receive health care, insurance was meaningless. It was necessary to develop a medical delivery system, a system staffed by doctors and others, and to train the personnel needed by the community. A personnel supply system and administrative leadership were needed. To allow independent management of health care through health insurance, it was necessary for the government to make constant adjustments in setting and reviewing reasonable medical charges.
Japan's medical insurance system has several weaknesses, but plays an essential role in supporting the health of the people. Health insurance provides the support for each individual to fulfill his or her abilities. Health insurance makes people's lives more stable and contributes greatly to the development of society and of the economy by helping people stay healthy.